Welcome to the Global Health Series. I'm Vivian Kosinja-Birchall, your host, and I am with a team of experts who are going to be talking about religion and global health. But to kick us off, I would like to invite each of you, based on who is on my screen, to introduce yourselves, tell us who you are and what you do and how it ties into our topic today. We'll start with Dr. Kenneth Ngwa.
Hello, Vivian. Thank you for this opportunity to be here. My name is Kenneth Ngwa. I am a faculty at Drew University Theological School. My area is in biblical studies, particularly Hebrew Bible. I am also, for the purposes of this conversation, the director of the Religion and Global Health Forum here at Drew, which came out of part of the work of the Global Health Catalyst. So it's wonderful to be here.
Welcome. Jochen?
Yeah, good morning, Vivian. My name is Jochen Kirsch. I'm director of Mission 21, a worldwide network of more than 70 churches and faith-based organizations in Asia, Africa, Europe, and Latin America since more than 200 years. I'm looking forward to be at the Global Health Catalyst Summit again this year.
Welcome. Fatmata? You're muted, Fatmata.
Hi, Vivian. Hi, everyone. My name is Fatoumata Barry. I'm from Niger, and I'm a research program manager here at Johns Hopkins Cancer Center. I'm working with Prof. Ngwa, and I'm working with the team to for the next upcoming Global Health Catalyst Summit.
All right, Dr. Ngwa.
Hello. Yeah, thank you, Vivian, for having us to have this conversation. So I am Will. I'm the director of the Global Health Catalyst collaboration initiative that we started at Harvard, and then Johns Hopkins. It's kind of extended to other institutions, really focused on catalyzing collaborations to advance global health and development.
Yeah, and Christine?
Hi, good morning. Thank you, Vivian. It's nice to be with you this morning. I am Christy Bankalari, and I am the director and co-founder of the Down Syndrome Foundation of Florida. I have been a participant in the Global Health Summits over the last couple of years, and I am sharing my expertise as a nonprofit that's not involved with religion, but that has a tie directly into it. So we're kind of like the feet on the ground. And thank you for inviting me this morning.
So we're excited to have this conversation. And of course, the common theme among everyone is the Global Health Catalyst. And we're here because of that. And so maybe to kick us off, we're just going to go straight into this year's summit. It's going to be held in June in Washington, D.C. And there is going to be a session on health or religion and health. So what is the focus of this panel? I'm assuming you guys will be on the panel. What's the focus of this conversation regarding health and religion, especially in light of the theme, which is the Cancer Moonshot 2.0? And I'll first start with Dr. Wilfred Ngwa, who is the Executive Director of the Global Health Catalyst.
Well, yeah, thank you. I think so this year's summit theme is about the Cancer Moonshot 2.0 and advancing collaborations to, advance global health and development. And, the theme, actually this year, because of Christy's wonderful suggestion, we decided that this year religion will feature through most of the sessions or throughout the days of the conference. And that recognizes the important role that it has in global health and in healthcare implementation. And Jochen had also had a great idea about making sure that and I agree 100% that as we develop interventions for healthcare and development, that religion has to be an integral part at the beginning and be one of the major stakeholders. So we actually expect this to be more integrative this year. Think about integrative medicine. So integrative global health medicine this year.
Right. So, I mean, which would take me to the question that I'm going to raise to each and every one of you. What is, first of all, the difference between religion and faith, and how do these two, how have they manifested in your work in healthcare and as religious leaders and as scholars? And I'll start with Dr. Kenneth. You're muted.
Yes, thank you so much for that question, Vivian. I do think that religion broadly defined, or spirituality broadly defined, is part of the ways that we understand our relationship with the divine, with one another, and with the environment. In other words, it helps us understand why we are part of this amazing experience that we call life, and how to care for it when it is fragile, when it is broken, or in this case, when it is unhealthy, and how to move that communal experience to a healthy state of existence that enables us to flourish, not just as human beings, but also as part of the non-human world, right? So that is how I see the role of religion, again, broadly defined, or even spirituality broadly defined. Now, in relation to faith, is that we have different confessions that organize people's religious or spiritual experiences. And it certainly varies. And there are many religious traditions around the world, both in the contemporary world and historically. So humankind has had a really amazing experience with religion, spirituality, and faith, which is dynamic and diverse. But we believe that it's important to harness all of that into conversations around health. So one of the ways that I often think about this, and this goes to why it is that we want to focus on this year, is I am always reminded of a statement that Martin Luther King Jr. made in 1966. It was during a press conference just before a speech that he gave at a convention of the Medical Committee on Human Rights, where he said that of all the forms of inequality, injustice in health is the most shocking and inhuman. And so my own thinking around this is that religion, again, broadly defined, not in the sense of proselytizing anyone, but in the sense of accessing religious beliefs and spirituality as a health asset, can allow us to engage in that ethical work of healthcare, which is to try to address the injustices, the inequities that are there in the healthcare sphere of life, not just within countries, but globally in the context of the global health catalyst. So that's one of the ways that I think about this in the work of the Religion and Global Health Forum. We want to invite people to think about how their spirituality informs their health decisions. A second reason is that I therefore think that religion is a social determinant of health outcomes in ways that we think about things like geography, we think about education, we think about finances, we think about race and ethnicity or nationality as social determinants of health. Religion and spirituality, broadly defined, is also a social determinant of health, because a lot of people, lots of communities consider their spirituality to be an integral part of their decision-making process when it comes to whether or not they access healthcare, or how they are able to get themselves to the place of accessing healthcare. So I often think about this in terms of the ways that I design. I talk about this in class. I talk about this with colleagues all the time. And so those are the two ways that I see this year's summit quite exciting, that we will think about religion not just at the level of implementation of health interventions, but at the level of research itself. Is it possible to include religion when we think about research itself? And that, to me, it's a kind of paradigm shift that allows us to appreciate the interdisciplinary work of the Global Health Catalyst.
So much to unpack there, including, something you mentioned at the very start, which was the bringing the historical component of religion, because it's, religion backdates the modern religions we have. So it's going to be interesting to see how that is included in the conversations. But over to you, Johan, your perspective.
Yeah, thank you very much, Vivian. I'm approaching that theme from a practitioner side, running a worldwide organization involved in international development cooperation. We look at religion as what Dr. Ngwa called a social determinant. Unlike the societies of like the United States of America or most societies in Europe, in the countries of the so-called global south, where we want to do our health interventions, religion plays a major role, and religious factors and religious actors determine, for example, the circumstances under which we want to improve women's health in Africa, to take an example. So when we take, just to maybe boil it down to a very practical example. When you want to talk about reduction of breast cancer or cervical cancer, and you want to support women in their health situation and to cooperate with them, you have to first of all engage in the cultural and religious context that you're moving into. So you're dealing with the issues of what does it mean to be a woman? Concepts of family life, concepts of fertility, intergenerational issues, just to start with. And you also, so if you don't get into those religious dimensions of that technical, we look at it from a technical point of view, but if you look at fight against cancer from a technical point of view, you have to, whether you like it or not, you have to engage into the cultural, religious setting that you're working in, and you will not be able to help any woman in Africa without understanding her social and religious context. And you will also not be able to support them if you don't deal with issues of gender justice, for example, or education or income generation, etc. So you have to really go have a comprehensive program approach, and you can't just look at one specific technical intervention isolated from the rest. And I think this is the great goal and the asset that the Global Health Catalyst Summit has, and it brings together people from different perspectives and creates a space for collaboration and exchange.
Fantastic. Again, so much to unpack when it comes to the intersection of women's health and religion and culture. And I guess this is why it's very critical to have these conversations happening here. And we'll get back to that later again. And next to Fatmata, please. Over to you.
Yes, so for me, faith is more personal, individual experience. And the religion, on the other hand, refers to a more organized system of belief and practices and rituals and worship. And I grew up in a country where religion is very, very, very prominent. But I remember the exact day when I really get the shock in my head that religion is extremely important in healthcare. It was in 2018, I was doing my an analysis on the data I collected from my thesis. And I was asking cancer patients what helped them decrease their level of distress throughout the cancer journey. either while they're having the treatment or beyond the treatment. And as a health professional, I was expecting, probably it's going to be the health professionals who, help them, or the psychologist, or, the oncologist. But the healthcare professionals were at the last bottom of the list. The first thing was religion, was faith leaders, faith community, religious community. And it was me in front of my computer watching the analysis and saying that, wow, now there is something here in front of me, confirming how important religion is. Because I grew up in a place where we have religion in every day. So you don't even think about it like when you are out of it. But sitting in there in front of the computer and seeing the analysis coming out that religion is the first thing which helped people cope and decrease the level of distress, it shows you how important we need to include religion in whatever process we're going through for any healthcare solution program or something for the patients, because it's part of their lives. And if we want them to follow the treatment, if we want them not to be lost, if we want them to have a better health outcome, then we should include actually this religion, because it's part of their daily lives. So for me, it was science, just bringing the evidence right into my face.
I cannot tell you how much I appreciate what you just said, because as somebody who works in communication, it's very critical for me to understand what needs to be communicated. And what I'm hearing, it's very critical to provide a platform for religious leaders to communicate to cancer patients specifically, because I have a very big passion about trying to find interventions for women in sub-Saharan Africa. So thank you so much, and we'll get back to that later. But Christine, over to you.
Thank you, Vivian. My experience isn't research. My experience is feet on the ground, and I'll tell you my involvement because it isn't directly related to cancer. But when I listened to the presentations, and on the third day, all the religious aspects came after research and education, I was like, oh, really? The faith piece of what they're doing at the Global Health Catalyst Summit is like the last mile. And it's part of everybody's everyday. And one of the things that I see running a foundation in the state of Florida is we serve people with all different religions and all different backgrounds. But as Fatoumata said, that is one of the key things that helps parents with children with Down syndrome get through life and get through a diagnosis. And it isn't the person that gives them the diagnosis, it's the community that supports them after. So I am a strategic person. I do strategic planning professionally. I do marketing professionally. And so when I look at things, I look at begin with the end in mind. So when we're looking at research and development, and we're looking at taking the excellent new things that are coming into that Will's developing in research, and it's getting into the people's hands on the ground, the way that we're going to do that, and we're talking about women's health or family health, is through their local communities. And most local communities involve some form of faith. And the other piece that I think is absolutely critical and important, and I think you'll probably get to this, is that it isn't just religious leaders that are saying that religion and spirituality are an important part of development and health. The World Health Organization, the USAID, this is a component now that's a pillar within development of countries, not just the healthcare system, but overall people are looking at this. And so I think it's a natural transition for this group to look at what does this mean for research and development all the way to treatment and long-term integrated care. So I'm super excited to be on the panel, and I thank you, and I look forward to the continued discussion.
Absolutely. And it's great that you brought on the international actors. We need them to be on board with this. So Dr. Ngwa, over to you about the same.
You mean me?
Yes. Oh my goodness, I forgot the Atungwas. Dr. Will,
You're comfortable.
your
Yeah.
perspective.
Yeah, no, I just say ditto. I agree with all the things that the previous people have said. Actually right now, there's a lot of, we know that with most interventions, data show that it takes a long time from the time that you develop a treatment or intervention before it actually gets, to all the big people that need to benefit from that intervention. So there's a new field called implementation research, which is really to kind of, facilitate that kind of transition. And what we are seeing from this data is that working with religious and faith-based organizations is critical. And so, I mean, I don't want to belabor the point. I think Kenneth and Jochen and Fatoumata and Christy have, really highlighted the key aspects of this. So, and just to add to Christy, so this year we are, that's why, this event is being supported by, National Institute of Health. So, there's that science piece. They actually really see connection with religion.
Right. So at this time, we'll just get it's a great segue into the next question, which is part of the recurring theme that you all pointed out was that at the end of the day, people they have faith beliefs, they have belief systems, they have religions. And so it is important for all stakeholders to approach this, especially global health stakeholders, to approach the interventions with cultural humility. And these interventions could be research, could be education, could be medicine. So my question to each of you is, in my opinion, what's the best way to address this with cultural humility during these global health conversations and during the interventions? And I'll start with this time, Johan.
Oh, thank you for the honor to start the round, Vivian. I think I would like to answer it in two ways. One way is we don't talk in Mission 21, we do not talk about development, because development suggests that one is developing the other. And that's and who is already clear from the beginning, who is the giver and who is the taker. We rather want to speak about development cooperation, where we meet with our partners on eye level. So the cultural humility you talk about, it means that we understand each other as that we need each other to make development cooperation really work, to create sustainable and impactful results. And to be able to do that, we have actually a way of including religious factors and religious actors into our development programming. So it's already a method. It's not only an attitude I have, but it's also a method we use to systematically include religious actors and factors in each step along the way. And we think that that's very crucial. And as Mission 21, we are not an aid organization that comes in and leaves again, but we are there in a context for decades or even centuries. So we build on long-term, trustful relationships where we have trust in each other, and we have already that basis for dialogue. And within that basis of dialogue, or in that trustful environment, we can then come in with ideas for develop interventions in the area of development cooperation, for example, in global health. So we have installed already a basis for dialogue within which we can then together develop that project or program that we want to do. And the result is that it is sustainable and impactful, because our partners, the churches, they don't come or go, they remain there. So they make sure that this program, this clinic or whatever is continuing, because it's their own. They have a sense of ownership for it. It's not we bring it and then we leave again.
Thank you,
I
Fatoumata.
hope that is a clear answer to the question.
Yeah, it is very informative. And I know Fatmata was also passionate about these components. So Fatmata, over to you.
Yes, when I think about, as Johan said, development and cooperation, I always think also at the end of the day, what do we want to accomplish? We want to better people's life and we want them to follow what we're bringing. But the thing that is coming to my mind is that we should see religious leader or faith-based leaders as key stakeholders when we're designing every solution. Like, we were not supposed to come as an expert. And in fact, I want to quote the late Paul Farmer, who was saying that the solution is always within the community. And may he still rest in peace. The solution is always within the community, which means we went to the schools, we had the degrees and we had the expertise, but then solutions are always coming from the community, which means we have to be able, that's the collaboration I think Johan is mentioning. We are coming with something and we were collaborating with what they already have and the power that they already have within the community. Because no matter how beautiful we come with a program, with a policy, if you're not involving those people, which communities believe in them, community have trust in them. So they are the leaders within the community because of the faith and other things. So if we take them as, you know, stakeholders sitting at the same table, we're now sitting and designing things and thinking about solution at the summit, for example. They are feeling that they are part of the conversation at the beginning. So that's a real collaboration, not designing things first and then going there and asking them to implement. They will be able to perfectly implement any solution you bring when they're part of the at the designing table. So I used to say that whatever we're doing for someone without the person, I don't think it's going to be something that is sustainable. It has to be with the person when you're designing the thing for the person, for it to be able to have a lasting impact within the community. So that's the collaboration development I'm seeing on both hands. We are all bringing different things, but we're all looking in the same direction, which meaning impacting the communities wherever they are, US, Africa, Asia, anywhere globally. We have our different religions, and even the people who do not follow any religion, they have a certain faith and they have some, trust in certain faith, based leaders. So that's the collaboration actually I'm seeing.
Fantastic. And it's also heartwarming to hear you talk about Paul Farmer. I'm a student in the department he created. So words that hits home for me. But yeah, so over to Christine.
Thank you, Vivian. When I think about cultural humility and the religious factors and then healthcare, one of the things as an organization that is not faith-based, the Down Syndrome Foundation of Florida, we are not a faith-based organization, but we serve people of all faiths and all cultures. And so what unites our group of people is a diagnosis. And under that diagnosis, all of our cultures and our belief systems come together, which I think is a really important thing when you think of things like Rotary International or other organizations that are addressing cervical cancer or other health issues. It's a non-religious organization that creates peace by respecting each individual's religion and culture, and therefore serving people with maybe a diagnosis, probably that in the healthcare system, I would say that unites people. And not that the religion goes away, the religion is each individual's religion and respected for who they are under the diagnosis. And I think that that's something that also is really important when we're talking about collaboration, is that we become a community of cancer, or we become a community of Down syndrome. And not that the faith piece goes away, but it becomes important that we serve each one in the capacity of where they are. And so I think it also helps us see what is the difference between serving a person of whichever faith if Christianity or Jewish or Islam or whatever it is. when you're serving them from a non-faith-based, you're serving all of them. And so I feel like I've been very educated in working with a lot of different religions, different from my own, but still very respectful of what their needs are and what their belief system is when we work with each one of those people. So I think while bringing faith-based organizations together, the other part is when you bring the NGOs that are not faith-based, they also bring a component of understanding cultural awareness and sensitivity that's important in healthcare and just global peace also. So they kind of all interrelate in my book.
Thank you, Christine. Dr. Kenneth? Avoiding the Angwa name right now.
Well, thank you. Thank you, Vivian. From my own vantage point, one of the ways that I think about the concept of cultural humility, and this is one of the areas where religious educators, people who find themselves in seminaries and training religious leaders or counselors who go out into the field to be part of a team that attends to someone who has just received a diagnosis. Fatoumata talked about that earlier on. That we think about the ways in which we can become more familiar with the language. Health literacy becomes an important part of how we think as religious educators, but it's also important to think about the humility in terms of the sense that it allows us to get at the issue of equity, because that's what inspires us to create that equity. So as Johan said, to see the other person eye to eye and to see the cooperation as vital to addressing the structural inequities that are there in healthcare access globally, because we are all aware of the disparities that are present, right? Someone in a particular zip code, has more access to health than another person in another zip code. They are both human, but it's their zip code that determines their health outcomes. And the cultural humility piece allows for us to create this collaborative work that is able to not only recognize those inequities, but offer solutions to it. So in my own space, I think about it in the education space, sort of, I draw on the work of, two medical professionals, nurses out in California several years ago who sort of wrote this piece on cultural humility in the health industry, Melanie Tervalan and Maura Garcia, talking about part of it is lifelong learning. And so even as we will talk about this in the context of the Global Health Catalyst, what we want to also communicate is that religious people are people who are really interested in knowledge. Lifelong learning is a very important part of what it means to be a religious person, always open to knowledge, to development, cooperation, and that, that allows for us to constantly see the ways in which we need one another in order to finally get at what we are hoping to get at, which is to create health equity for everyone. So that's one of the things that I think about when I think about cultural humility. It's the capacity to infuse in our own spiritual spaces the undying thirst for knowledge and growth and flourishing.
Oh, thank you so much. I mean, this is a great segue into the final. We could go on and on, but we have to keep this interesting conversation a little shorter. But getting us back to the Global Health Catalyst Summit, and to the first theme, I think on day one, I don't know whether I should be saying this, but will be around cervical cancer. So, and this conversation is going to be cut across all the themes. So I'm particularly interested in cervical cancer. So I'm taking the privilege, using the privilege to just throw this out here. If it is a huge burden, the disease burden is huge. in sub-Saharan Africa and other low and middle income countries, East Asia, and name it. If we are going to use to integrate religion and healthcare in addressing cervical cancer, either increasing women's response to screening, we need to engage the men as well so that they can support their women. So that it's so how can we approach this? Yeah, I think I will start with you, Dr. Ngwa. Thanks. Oh, Dr. Will Ngwa.
Yeah. So the first day of the summit this year, we're very excited about that. It's going to focus on the cervical cancer, and obviously the Cancer Moonshot also wants to prioritize this. And yeah, women's health is really critical. If you talk about lower middle income countries as well, there is a great I mean, women are the engine, for example, of society in Africa, and so it's really important that we make sure that they're healthy. And because of the HIV/AIDS, the number of risk factors around cervical cancer, that's increasing. The likelihood of you getting cervical cancer is HIV/AIDS. And so as many people get saved from HIV/AIDS because of really wonderful programs from the United States and other places like PEPFAR, now people are beginning, a lot of women are now facing the burden of cancer. And so we now need to come together and also, as part of our work with the Global Health Catalyst, we really engage the White House around, taking that to the next level and also doing something similar to the level of PEPFAR for cancer. For example, establishing a Global Cancer Fund, which is something that we're going to be pushing at the summit. But like you mentioned, the role of men is really, really critical. Actually, just yesterday, we had a lecture with Fatimata at Drew at Kennedy University, basically talking about, how in most of these societies, women, need to get permission from their men sometimes to go get healthcare access. And it's still a very common thing in most countries. And part of that is informed by the religious cultures and things like that, And so being able to get the faith-based leaders to be able to say, yeah, this is okay, to be stakeholders, like we've all been talking about from the very beginning, and for them to then give that, permission, to be able to say, this is something that we need to do. And then the men themselves and everybody, not only the women, the men and the women now, can be able to have that permission to go out and adopt that intervention. So it's really, really critical that we involve the men for sure. And really the religion has a big part, in being able to influence that.
Thank you. Anybody else want to take it?
If I pick up from that, I would just say that spirituality, religion allows for us to understand our interconnectedness as human beings. And so women's health is human beings' health. Women's health is universal health. Women's health is global health. So it's important to say that because religious communities have a way and a platform to basically allow for us to think about what it means to understand the significance of the human body. And so cervical cancer, if it is something that is attacking the body, religious leaders can come up with language to talk about why it's important to go for screening and to do everything that one needs to do to get treatment. And because we think about it in a holistic sense, the men should be there cheering and supporting, because that decision is also an economic decision. It is also a cultural decision. It is also a family decision. And it has to be everyone participating, collaborating to address cervical cancer. We all have a stake in it. The women bear the burden, but we all have the stake in it. And it's important for religious leaders to say that not just once in a while, but repeatedly.
Thank you so much. The two of you started a trend. We'll now listen to the other gentleman, since we have three men here. Take the lead in this.
Sorry. Yeah, excuse me. I think our faith-based partners share with us the goal that we want, sorry, we want healthy and strong women as part of a healthy and strong family, as part of a healthy and strong society. You can't, you can't heal a woman without healing the society, because a woman is part of it. And our faith-based
You
partners.
need a minute? Sorry.
No, it's okay. Our faith-based partners are, you can say, catalysts for change, catalysts for healing in a society. They are catalysts for changing and improving the situation, the overall situation, not only the health situation, but the overall situation for women in African societies. Because those faith-based organizations, churches, or Muslim organizations, whoever, they are part of the society, and they are catalysts for change to improve women's access to health, women's rights, and they also, and they improve gender justice, so that concerns the relationship with men, it concerns all the relationship with the overall family or social context. And I think we have to look at it in this comprehensive way. And that is what I think the catalysts, the global health catalysts are actually doing. They want to be catalysts for change and using faith-based organizations as those catalysts for social change on behalf of the women in Africa.
Thank you. Thank you. And now to the ladies, Fatmata, do you have anything to add to that? And then Christine?
I think just to add on, I think we can still go back to the social determinants of health and understand why we get to the position or to the place where a woman needs a permission from a man to go seek one of the basic needs of a health of a human being, which is healthcare. So for us to be able to, you know, have a solution for this problem, we may have to go back and understand what was, you know, what did we do to get there, and also used the religious leader, because they are people who are trusted and they have the knowledge in the religion, in the faith, that the other people do not have. Some people are following the religion, but they do not have the core understanding of what it is impacting. So maybe the religious leader could be the catalyst, right, to unpack actually this problem and explain to people that this is not what is supposed to be. A woman, as Prof. Kenneth Ongwa said, she's a part of the humanity. She's a human, as same as the man. So she has also the right to be able to go and have access to care. And somebody, not even a husband, anyone, shouldn't be a barrier preventing her to go seek treatment. And I remember on our yesterday panel, a lady asked, okay, if the man doesn't want the woman to go seek treatment, can we think about maybe because of the woman is the one taking care of the children, cooking, doing everything in the household while he's out looking for money. So if she's not there, who's going to take care of all those people? Then that's again going back to the social determinants of health. Even if we are explaining to the husband that, you know, you shouldn't be a barrier for a woman to seek care, we should also be able to address, you know, all that a woman was supposed to do. Even if we do not agree on that, but we have to actually take care of that so that she will be able to find in herself the right way to go and seek the treatment, not thinking of, if I go seek the treatment, maybe my children will not have food, or who's going to take care of them, etc., etc. It's a whole long list of things to think about, but probably starting with the religious leader being as a catalyst and unpacking why we got there, and how should we go beyond that so that a woman can just be as a human as the man.
Well, as a woman and a caregiver and a chief executive officer of my home, I speak as a woman that says that looking across societies as a whole, women do a lot of what we consider unpaid labor, right? They care for the home, they care for the community. They tend to be the volunteers that are filling in gaps where maybe government doesn't fill in. And I think that sometimes that's a really important thing, that there isn't a financial component to all of the work that a woman does, but the essence of what she does, that's why I always say chief domestic officer, is she runs the home. And if the home fails, the children fail, and then the husband fails, and then the society fails. And so healthcare is something that is human dignity and justice and caring for people, but it's caring for the society, and it's caring for the state, and it's caring for global health. And one of the things I love about the summit is they talk about global health is local health, and local health boils down right to the home. It's not just the city, it's the home. If the caregiver is cared for, the trickle up effect is multiplied. And so I think that that's always something really important is, and it's, you know, if it's cervical cancer, if it's mental health, if it's addiction, whatever the overlying or overarching piece that impacts the woman, and in this particular conference, it's cervical cancer, but that lends itself across all diagnosis and issues. So women's health is global health. And I think that looking at it from a local and religious, because at the end of the day, that's where I start my day and end my day, is very important. The statistic is over 83% of the world practices some kind of religious practice. And so it doesn't matter what that is. If there's over 80% of the world practicing it, then we need to be listening and focusing on it from the beginning to the end. So that would be my 2 cents on the topic.
That is such a fantastic wrap up of this whole intersection between health and religion. And so I'm just going to give one sentence to each of you, one final word for our viewers. I'll start with who hasn't started? Christine.
Well, I'm just really excited for people to come, and we have a fabulous program from beginning to end, from research to faith, and how they all intersect and collaborate, and how bringing these dynamic forces together can create positive change in many societies. It's a summit that I never knew that I'd be a part of, and I'm so happy to be a part of it. And I think no matter if you are a scientist, if you're a researcher, if you are a faith-based person, if you're just interested in global health, or if you're interested in global development on a collaboration scale, it offers something for everybody. Even if the platform is cervical cancer, there's many other aspects of this that reach far-reaching into communities. They're far-reaching into communities. So thank you, Dr. Ngwa, Will, for putting this together and inviting us to be a part of this, because each year it just gets better and better. And I thank you.
Dr. Kenneth Ngwa.
Yes, thank you. Also, I am extremely excited about this year's summit, because it really does represent some of the highest ideals and visions of the Global Health Catalyst. And so for me, I'm just I hope that people can attend either in person or online. You will find that it is global in the sense that it really does put together multiple things together in a very interdisciplinary way, but also in a way that feels local, that feels immediate, that feels germane to the work that people do on a daily basis. And so for me, it is that as we talk about the social determinants of health, and we talk about the role of religion, my own belief is that the Global Health Catalyst is saying, if there are these structural disparities, we can fix them. And I just think we have to believe that and get at it.
Thank you, Johan.
Thank you, Vivian. I talked before that, in my point of view, it's important to talk about development cooperation. And for me, the Global Health Summit is exactly such a sphere for cooperation, where we bring together actors from different perspectives, researchers, practitioners, foundations, organizations of a different caliber, and we are joined together because only together, when we cooperate in development, we are able to move global health forward. And this is why I'm really looking forward to the Global Health Catalyst Summit in Washington this year.
Thank you, Fatmata.
Yes, I think it's going to be very exciting and very interesting, and I urge everyone to be able to attend, no matter which field you're working in. It's an incredible program designed to think about our multifaceted challenges in the world with a very dynamic and diverse program and expert from everywhere. So please join us. And we even have a platform for young people, which is very, very exciting. And I'm looking forward to that.
Finally, they say you never speak after the big boss. So Dr. Will Ngwa.
Yeah. Yeah, I'm not a big boss. So actually, one of the talk about humility, the great thing about a catalyst is really that the catalyst is, it's not the most important person in the reaction. And that's been the thing, like everybody has said. So you come at it, it's about collaboration. Everybody is important. So the wonderful thing about the summit is you can come and meet the president, and you can meet the student and the homeless person. I mean, at all levels, you can come there and they are sitting on the same table. So we usually say when people come to the summit, leave your title and your ego out at the door before you walk in, because everybody, we're really here to collaborate. And if we collaborate, like the Africa saying says, if all of us come together and collaborate, we're going to go far and overcome. There's nothing that can stop us. We can eliminate all these, whether it's cervical cancer or other health challenges that we're facing. And I want to say, that one important part of the development piece is that, really when we always think about the healthcare, but the impact of it on development is also huge, right? So if you have a healthy society and everybody's working, the women are healthy, then the economics is also good, everybody grows. So the impact is also great. One last thing I want to mention is that with the Cancer Moonshot, we've actually really disengaging. That has really been in a way that we want to make sure that the global health and local health aspect that Christy mentioned, which is that, as we collaborate, the United States is investing into this, or whoever the stakeholders are, it's going to benefit not just women in Africa or Southeast Asia or Latin America. We want to make sure that it benefits the woman in Alabama, in Baltimore. And so that's the unique aspect here also, to make it sustainable, so that everybody sees why their investment is win-win, right? So a key aspect of that is win-win. Everybody collaborates in a win-win way. So yeah, very excited about the program this year. There are wonderful speakers. And then obviously I'm so excited that, we can have this religion aspect going through. So come there, you will see Kenneth and Jochen and Christy, and of course the young people. A good model for that is Fatimata. You're going to see everybody. And then of course you, Vivian, you're going to be there to talk to people, so everybody has a space there. So thank you so much.
Thank you. It reminds me of the phrase, a rising tide lifts all boats. And this is what I'm seeing the GHC do. It's rising all the boats, and so that we all have, a chance at life, at a healthy life.
Yeah.
So with that, I want to say thank you again for being my guest on this show, for the fantastic input, for the informative perspectives. And I look forward to hosting you again, and to listening to your presentations at the Global Health Catalyst Summit. And to our viewers, you can learn more about the Global Health Catalyst at globalhealthcatalyst.summit.org. And for now, thank you for watching. Till next time.